Hello, everyone. Good morning, good evening, good afternoon. This is Qaiser Mukhtar with the U.S. Centers for Disease Control and Prevention with my CDC TEFINET and the CDC Foundation colleagues. Welcome to part 2 of Interpretation of Study Findings series. We appreciate you joining us today. And as always, we ask you to please introduce yourself in the chat box, write your questions in the Q&A tab, and we will send you the webinar recording link and slides by next week. We will also share a link to the written questions and answers from the last session and this session, from each session. And we really appreciate your participation in the webinar, in quiz, and evaluation. It's very encouraging to see that not only you attentively attend the 90-minute session, you participate in the quiz questions, and then you take time to provide helpful evaluation feedback. I wish I could read all of the comments and suggestions, but it seems like that not only the series is helping the trainees and the junior staff, but also helping the mentors and faculty in being able to explain the concepts to their students. And one of the comments we hear over and over is how Professors Welton, Lackland, and Weber explain very complex concepts in simple terms. So thanks again. Today, Professors Lackland, Welton, and Weber will share their extensive experience and insight as clinicians and researchers to help us understand the accuracy and the value and meaning of sensitivity and specificity of diagnostic tests and the applications of predictive values in clinical epidemiology and evidence-based medicine. So with that, I turn it over to you, Professor Lackland. Thank you.
Thank you very much, and it's very exciting, and I appreciate everyone joining us. This is kind of an important and very exciting type of an area. It's a little bit complicated, but it's so important as whether you're into the diagnostics, if you're into screening, if you're into any type of aspect that includes some type of a test. This is do it. Our next session, part 3, will also be, this will be kind of an extension of some of these pieces, but the points of sensitivity and specificity are just really key. Many people mess this up. They get it confused, and this leads us into a lot of problems with our diagnosis, whether we're determining a prevalence, whether we're determining a condition, and having those concepts of sensitivity and specificity. So we want to go through the different details and the different pieces. Our typical disclaimer that this is our opinion, not necessarily the official position of the CDC. Today, we'll talk about the accuracy of a diagnostic test, the value and the meaning of what is sensitivity and specificity of a diagnostic test. We'll describe the application of predictive values. We'll do more of this next session as well, but kind of leading it through. And I also wanted to share a number of examples that we have of how you look at it, making the interpretation, and hopefully helpful to you. The first part that will be consistent all the way through, and I know you know this, but what is the role of a diagnostic test? Why do a test? Whether you have a research project, whether you have you're looking at a population, why do or you're in a clinic, why do you do that diagnostic test? And it basically is to reduce the uncertainty for a specific patient's diagnosis. Test characteristics, you always want to think about before ordering a test to determine whether a given test would provide a good meaning? Is it a good value before you just simply randomly order a test? And you will find sometimes people just do these tests and they don't really ask that question. Why are we doing this test? What do we want to see? The purpose of the test is to identify with high accuracy. Let's underline that and bring it through. The disease of a particular patient and basically provide some type of a follow-up, an early or proper type of treatment. Sometimes it's a prevention. It's a number of things. But we do a test because we want an accurate assessment such that we will do something. This is this thing, and we're going to do this over and over. So I thought I'd just introduce it right here. Basically, this is our 2x2 table. I'm sure that you're probably all of you are very, very familiar with. We see it. We have an index test that we do that can come up to be positive or negative. And then we compare that to our gold standard. And this is, if you're looking at cancer, this might be pathology reports. If you're any type of what is determined for a particular condition, the gold standard, whether it be a different laboratory measurement, something that can be confirmed that you say, this is really the disease. So the person has the disease or does not have the disease. And here's our 2x2 table. The test was successful and identified the true positive. The test came up negative and identified the true negatives, but you also have these other issues of the false positive and the false negative. And this is where we need to kind of think. And this is where sensitivity and specificity will play a role. These are the terms, and I just kind of present these here, and I know that you're familiar with this more of in textbook type of fashion, but we're going to be referencing this as we go through and think about diagnostic tests. And we're going to do more definitions, and there'll be a little bit of repetition, saying duplication of different terms. But this is so important to kind of guide our way into how we think about things. The first is the sensitivity, the proportion of subjects who have the disorder and who have a positive test. The specificity, the proportion of subjects who do not have the disorder and have a negative test. The positive predictive value is the proportion of subjects who give a positive test and have the disease. The negative predictive value is the proportion of subjects who give a negative test and do not have the disease. The likelihood ratio for a positive test is how much likely is the positive test found in a person as opposed to without it. And the likelihood ratio of a negative test is how much more likely is the negative result to be found in a person with the disease of not having the disease. So these are the kind of parts of the equation that we would want to think about. Very importantly, when you're doing a test, you ask yourself the question, why am I doing this test? Why am I implementing the test? Am I doing it for screening, which would ask the question, which patients have an asymptomatic disease? That's why you're doing the test, to see if they have a disease, or screening. Diagnosis, which patients have a symptomatic disease. Doing the diagnosis, now the person with the symptoms of the disease. Diagnosis. The predisposition, which patients could develop the disease. They're looking for some type of an indicator of developing the disease. Monitoring, which many of us do. Is the disease controlled? How advanced is the disease? Has the disease reoccurred? All kinds of conditions, whether we're talking infectious disease, we're talking non-communicable diseases, chronic diseases, all of these pieces. Prognosis, are we doing a test for prognosis? Will the disease progress over time? Are there indicators of such? And then we also do a test for effectiveness. Is a drug or an intervention being effective? And how do we measure keep doing it? And so we want to kind of think, why are we doing a test? Okay, different types of reactions that are here. And just one more, why are we doing a test? We can do a test for confirmation of a diagnosis, triage to move someone into part. Monitoring, as we've already said, prognosis, and screening. Again, with this kind of thinking, why are we doing this test? What do you want to do with this test? Always remember, they got to be accurate on all of these. It's no good if it's not accurate at all, which is where we are now. Very important, thinking about that characteristic. How good is our test? What is the accuracy of our test? This is the proportion of subjects who give the correct result. Our false positives, again, kind of thinking, is an error resulting from the incorrect indication of a disease presence, i.e., the result is positive when in reality the patient is really disease-free. So you're telling someone they have that this test is indicating you may have such and such a disease. We're going to do examples, but in reality, they don't have the disease. Bring in thinking about this. Are you doing harm? Are you doing something in a variety of ways? And we'll talk more about it. The other piece is the false negative. This is the error resulting from the incorrect indication that the patient does not have the disease. In reality, they do. Okay, here it is. We did a test. Here it is. Whether we think we want to do infectious disease, STDs is a prime example. We could also have other, particularly the chronic diseases, telling someone that they don't have cancer. In reality, they do. So the effects of the false positives and the false negatives. Now we're bringing here, what are some of those indicators that help us do something? These are just basically the concepts that we have when we're looking at a test, things that you have to kind of consider. And it's at this point, my feeling, and I feel like Dr. Weber, Dr. Welton are going to kind of agree, this is so important, not just to know these values, but to know what the values mean when we're evaluating if we're going to use a particular test and do something about it. How good is that test? And more often than not, that's kind of up to all of us to be able to understand these concepts. The first, the sensitivity of a test that stays with that test, the ability to detect people who do not have the disease, who do have the disease, excuse me. This is what many people will call it a rule out, and we'll talk more about that. The specificity, the ability to detect the people who do not have the disease, ruling in. The positive predictive value, the likelihood that a person with a positive test result actually has the disease. And the negative predictive value is the likelihood that a person with a negative test result truly does not have the disease. Two pieces, and we're going to say it again, but it's so important. Sensitivity and specificity never change. They stay with what that test is. So here's the test, whether I do it on whatever population, this stays the same. Sensitivity and specificity are associated with the test. The positive predictive value is basically affected by how many people have the disease. And this is going to be important to kind of consider, but that does change with how many people, what the prevalence of the disease is. Sensitivity and specificity never change. So here it is, again, going back to our 2x2 table, what we can think. So sensitivity is dealing with those people that actually have the disease. And you're doing a test. You can have a positive test, negative test. So if the person has the disease, they could be a true positive. The test says, yes, you have the disease, and you do indeed. But for sensitivity, you could also be a false negative, right? So the test said you don't have the disease. In reality, you do have the disease. So sensitivity, people that have the disease. Specificity, people that don't have the disease. So the people that don't have the disease could test negative. That would be our true negatives. That's what we want, right? But people that do not have the disease could also test positive, and that would be a false positive that's here. So specificity, people that do not have the disease could be false positives or true negatives. If we think about our positive predictive value, these are people that test positive. So they could be the true positives, or they could be false positives. And likewise, they could test negative, they could be a false negative, or they could be a true negative. You kind of say it, and the reason we say this over and over again, because it's a little bit counterintuitive. You're thinking, okay, false positives, and kind of thinking about it. But as you consider this, it should start to kind of flow. But this is why we say it over and over again. So in diagnostic testing, again, we've already said for the positive predictive value, negative predictive value, the disease prevalence can make a difference. For sensitivity and specificity, the prevalence does not make a difference, and this is specific to the diagnostic test. When we get to our positive predictive value and our negative predictive value, the prevalence makes the difference, and this is the direction that we're seeing. And we're going to do a little bit more. So let's think about the characteristics of a diagnostic test. First, the sensitivity, the probability that if you truly have the disease, the diagnostic test will catch it. This is where we're thinking. So you're evaluating the test that's been put before you, or the test that you're going to consider to implement right up in here. The sensitivity that you're interested in, if you truly have the disease, the diagnostic test will catch it. You'll get it. It'll be positive. Specificity, on the other hand, the probability that if you do not have the disease, the test will register negative. This is the part. So thinking about, what are you measuring? What is the purpose of this study? What is the purpose of this evaluation? What is the purpose of this test? What do you want to do with it? And now kind of thinking, am I interested in the sensitivity, specificity? Clearly you're interested in both, but you're maybe one or the other. What are you interested in? What are the big effects? And this is where we now come back in, if we think again about sensitivity. Now we're thinking sensitivity, and a term that you've probably heard and been familiar to is SNOUT. And basically this is saying that a highly sensitive test is good for screening, or SNOUT. A highly sensitive test, sensitive, negative, rules out the disease. This is where you have SNOUT ruling out a particular disease. The equation, again, if we're talking sensitivity, there's people that have the disease, and what percentage of those are you getting the true positive? If we think about SNOUT a little bit more, ruling out the disease, the rule of thumb is using a test with a high sensitivity and a low specificity. So for example, genetic testing for a disease that has a 99% sensitivity and a 54% specificity, and then you basically have your positive likelihood ratios are good, and your negative likelihoods, but you're focused in on the positive. You're focusing in on ruling out the disease, and you want a high sensitivity that's going to be able to accurately identify a particular disease and a particular condition. This is a genetic type of part. So thinking about that rule of thumb, kind of getting it into your head, and we're going to do some more examples. In sensitivity, when a test sensitivity is high, it is more likely to give a true positive result and correctly identify the disease or the illness when it's present. In this case, a test with a low sensitivity is more likely to produce a high number of false negatives and may miss identifying a disease or a condition. So you think about it, if your disease or a condition, if certainly it's a disadvantage for everything, but if it's at a particular, you're doing particular harm, to have a test that's going to be having a high number of false negatives, i.e. a low sensitivity type of test, this is going to be a concern, and you may want to say, this is not a good test for me. Now let's go to specificity, same type of piece. Specificity, SPIN. Imagine many of you have heard this. A highly specific test is good for ruling in a particular disease. A highly specific test positive result rules in a disease. So here is a condition, specificity. Now we're looking at only people that do not truly have the disease. Okay, and here is our equation. A little more on spin. The rule of thumb is for using a test with a high specificity and a low sensitivity. So for example, here is our hemoglobin A1C for diagnosing diabetes. It has a 99% specificity, relatively low sensitivity, and a positive predictive value, a positive and negative likelihood, excuse me, very high for positive and very low actually for negative. So this is going to be ruling in the condition. It rules in there. So this is an ideal looking at this condition, ruling in that we see people with the condition. A little more. For specificity, a highly specific test means that there will be few false positives. So now we're building it in. So this is going to be our ruling in a particular condition. It may not be feasible to use a test with a low specificity for screening, since many people without the disease will screen positive and potentially receive unnecessary diagnostic procedures, kind of doing a little bit of harm, doing things that we don't need to do because the test had low specificity. Again, what are we conditioning? What are we looking for? What do we want to do? And what do we want to see with regards to specificity and sensitivity? A negative result from a test with a high specificity is not necessarily useful for ruling out a particular disease, which is why it's not SPOUT. Here's an example. For a test that always returns a negative result, will have a specificity of 100% because the specificity does not consider the false negatives. The false negatives are in the part with the sensitivity. This is where we're kind of putting it in, getting a little bit of thought. We're going to do more of these, so just kind of keeping the thought process going. If we think about there basically is testing, there's no point in testing if the result will not guide management. That management doesn't necessarily have to be a treatment. It can be and it should be, but it needs to be some type of response. So even if you're using this for monitoring a disease, if it does not helpful in doing some type of a response, some type of reaction to it, there's no point in doing the test. And that's an important piece. And some of the rule of thumb for doing the testing is when the sensitivity and specificity are moderately high and the positive and negative likelihoods are either high or the negative likelihood is low, or it's lower. So this is the piece that you want to see and that you want to think, do I want to do this test? It's very difficult if you think again about doing a test that's not very accurate, that's not missing in there. You're providing false information. People don't know what to do with it. It's a waste of resources, but it also confuses so many individuals, including myself. So it's such an important piece and such an important point. This is just one more, it's a little bit lengthy on the test, but it's again emphasizing the likelihood ratio. And the likelihood ratio that you're building in it, that you're going to use a test, is that the test would be expected in a patient with a target disorder compared to the likelihood that the same result would be expected in patients without the target. So again, this is this positive value and the negative value. A likelihood greater than 1 indicates that the test is associated with the presence of the disease, whereas a likelihood ratio less than 1 indicates that the result is associated with the absence of the disease. So you're looking at fairly high positive levels, and then you're also looking at values less than 1 that are indicating the value of the negative component to it. The further that the likelihoods are away from 1, the stronger the evidence for the presence or the absence of the disease. So it's further away from one going in the more than one direction, then it's going to be associated with the presence of the disease. The further it away less than one, it's going to be the absence of the disease. And you don't need to get into the hard part of it. Is you're just being able to look at these numbers and assess the value and the accuracy of the test. This is a little bit complicated, but it kind of goes back to the spin and the spin aspect of it and kind of showing it. Remembering now, what are we doing? We're going to do the spin, and the rule of thumb for using a test is basically a high specificity spin, ruling in the disease, high specificity, low sensitivity. Okay, so I'm now going to be kind of focusing in on the idea that the people do not have the disease. And I'm going to do the test to basically rule in the disease. So I'm thinking that the people don't have the test. Here's the test to rule in the condition. And I'm going to do this test to see whether to rule in the disease. As opposed to SNOUT, looking at the sensitivity, the rule of thumb is to using the test with a high sensitivity and low specificity. These are people that are probably likely to have the disease, and I want to do the test to rule them out that they don't have the disease. So this is kind of thinking against how important is the disease and the concerns with the false positives and the false negatives. So again, spin, SNOUT. But also we're going to have to do, for those of us that are doing some of the tests, and again in the diagnostics, and we'll talk more about this during our next session, but our positive predictive value. This is the probability that you test positive for the disease, you actually have the disease. It depends on the characteristic of the test, the sensitivity and the specificity and the prevalence of the disease. Okay, again, different sensitivity and specificity, doesn't matter the prevalence. Positive predictive value, it depends greatly on the prevalence of the disease. So this positive predictive value, kind of the concepts that you have of it, and we're going to go into more of this. Disease with a prevalence of 30%, again, must be diagnosed. The test has a sensitivity, specificity of 50%, specificity of 90%, and given a positive test, you think about what is the chance that the person would have the disease. Very likely, and we're going to do an example, maybe, unlikely. This is the kind of concept that we have with a positive predictive value. So here's an example. So all of us, and probably every one of you, have had this kind of conversation, whether it be a family member or a friend or whatever. Your father telephones you and tells you that he went to his doctor and was told that his test for his disease was positive, and he's really worried about it. And he asks you for help. After doing some reading, you find out that for men at his age, the prevalence of the condition, whatever you want it to be, is 30%. The disease has a sensitivity and specificity of 50% and a specificity of 90%. His question again, daughter, tell me what's the chance I have the disease? Really worried, simple type of stuff. You've got your information. So let's go through our calculations. Okay, we have a prevalence of the disease at 30%. So if we had 100 people, 30 of them would test positive for the disease. They would have the disease. Now we're interested in the sensitivity. And 70% would not have the disease. Looking at the prevalence, no disease, sensitivity, specificity. Looking at the denominators. So if we look at sensitivity, we know that 50% of the people that have the disease will test positive, 15%. Here, For no disease, we know at 90%, we know that that 10% will be false positives. And so we have 7 here that would be there. 10% would be 7 because we have a specificity of accuracy. We're looking at testing positive, giving us 22 people, of whom 15 have the disease. Okay. And so, Dad, you have about a 70% probability of having the disease, giving this particular scenario. Fairly easy to do this, kind of high probability. But let's take the same scenario, but with a lower prevalence. Again, we're looking at the positive predictive value. So now the disease has a prevalence of 4%. The sensitivity and specificity are going to remain the same at 50% and 90%. If the patient tests positive, what is the chance now that the person has the disease? Whatever we've done here, but with about a 4% chance. So let's go to it. Our prevalence now would be 4%, or 4 people out of the 100, meaning 96 would not have the disease. Sensitivity at 50%, so that's going to mean that 2 will test positive this time. But it would mean, again, that 10%, right up in here, 9.6%, just bear with me for that, that's the actual calculation, would also test positive, giving me 11.6%, of which 2 actually have the disease. Now, Dad, now you have about a 17% chance of having the disease. Much less, right? Much less, much more comfortable. Thinking about now, the positive predictive value, unlike sensitivity and specificity, are greatly affected by the prevalence of the disease. So let's calculate a little bit more as we go into some more and additional types of examples and additional types of studies. So if we calculate sensitivity and specificity from the 2x2 table, and this is pretty much textbook, here is how we calculate sensitivity. Again, people with the disease, and basically that's it. How many tested positive over the people with the disease? And again, among those with the true disease, how many actually tested positive? Specificity, on the other hand, the people without the disease, again, the people that test negative over everyone that actually did not have the disease. Among those without the disease, how many tested negative? And just kind of running back through that again. Now let's work into, again, we talked about what is your condition that you're interested in. You're going to be doing some evaluations. You're going to be doing diagnostic tests, whether this be monitored, whatever the condition is, you're wanting to do some tests. You have to think about the other conditions. So you're thinking sensitivity, you're thinking specificity, but now you're also thinking about the importance of doing this test and thinking about other pieces, the conditions of it. Do you do this test in everybody? Do you do this test? And now you know you have to think about what is the prevalence of the condition. So let's take a hard condition, mammography and breast cancer. You want to make sure that you identify the people with cancer, but you want to be particularly concerned that you do not tell a patient that there is no problem when the disease is actually present. So, right? So you want to make sure that you're getting the women that with abnormal there, that you're bringing them into treatment early, because this is such a devastating disease, and that early diagnosis is so very, very important. Thus, you're actually going to accept a few false positives in order to minimize the false negatives. So that's your attitude about mammography. That's your attitude about the value of the early diagnosis. It's so important. You're willing to take a few false positives and tell some women that they have an abnormal smear. They may have something lead them, and you can word that how you want to do it. But you want to minimize the false negatives, to not let someone go out and have breast cancer and you failed to detect it, or your test failed to detect it. Also kind of building in now, that also conditions of how we think about how we calculate the sensitivity and specificity. Here it is with just in general parts in here with breast cancer and mammography. You can see our true positives. We have one false positive. When you look at the other conditions, we calculate our sensitivity is the people with the disease, 9/10. These are people with breast cancer. 9/10. Our sensitivity would be 90%, and we would have one false negative out of 10 cases right here. Our specificity, on the other hand, would be 89%, taking the number of people that with a true negative over the total number of people without the condition, which would now tell me I'd have 109 false positives. Remembering with mammography, I want to limit the number of false negatives. I'm willing to take a few false positives to offset. I want to have very few false negatives. But now let's thinking about what are the factors that affect the effectiveness of screening for breast cancer. Okay. Now, again, the prevalence risk of the disease. And now we're thinking more of age categories. The effectiveness of screening in preventing illnesses. This is something that we think about with mammography. Is the test good at detecting disease or the precursors, the sensitivity of a test? Is the test detecting a clinically relevant condition? Another type of consideration, certainly for breast cancer, is yes. Is there anything we can do if the disease or pre-disease is detected? That can be treatment, that can be cures. Does detecting and treating a disease at an early stage really result in a better outcome? Important piece. Again, what's your condition? What are you trying to do? Can you do something? Important considerations here. And finally, also, what are the risks of screening? And this could be false positives in the case of breast cancer, and mammography could also be radiation. So again, with mammography, again, if we think about what those risks are, mammography utilizes ionizing radiation at a typical safe imaging, but it also still is offering ionizing radiation. Again, the mammography, the examination is performed by compressing the breast firmly between a plastic plate and X-ray, as many of you already know. Mammography, again, can identify breast cancers too small to detect on physical exam. And early detection and treatment of breast cancer before metastasis can improve a woman's chances of survival. And studies have shown that among women 50 to 69 years of age, screening results in 20 to 35% reductions in mortality from breast cancer. Looks like really a very, very positive thing that I want to build in, and that these issues that I do see with my minimizing false negatives is important. However, let's just kind of look at this we look at mammography. Then why not mammography for everybody if this is really good? Because there are discrepancies that exist over the efficacy of mammography at reducing mortality in breast cancer in women 40 to 49 years of age. Again, mammography has a high rate of false positive tests in this group. That causes anxieties and basically necessitates further costly diagnostic procedures that are going through, kind of a condition, as well as some of the radiation exposures that might be there. And again, the mammography exposes some women to some radiation that might slightly increase the risk unnecessarily, perhaps. So here's our case example. We have a 60-year-old woman has an abnormal mammogram. What is the chances that she has breast cancer? I.e., we're looking for a positive predictive value. And again, we have our 2x2 table here. And again, reminding you of what our calculation is now for our positive predictive value. Now we're looking for, was the test positive or negative? Again, positive predictive value among those who test positive, how many will truly have the disease? Negative predictive value among those who test negative, how many will truly not have the disease? If we look at this example here that we do have, again, this is the one that we just looked at for the 60-year-old woman. The positive predictive value would be 7.6%. And the negative predictive value would be 99.9%, as we've considered. And the prevalence of the disease at this point is 1%. But now let's look and to see where we are, and we're thinking about our false positives and our false negatives. What now if the disease was twice as prevalent in the particular condition? Or in this case, breast cancer in this particular condition. Again, sensitivity remains, it would be effective with the test, and the sensitivity here is 18 over 20%, and that we have. Our specificity 89%, and the sensitivity and the specificity are going to remain. The part characteristics of the test, they're not going to change, regardless of if the population was even higher. Again, another reminder of that. However, if it's more prevalent, and now we look at the positive predictive value and the negative predictive value, now the positive predictive value in a condition that is more prevalent, i.e. the age group has a higher prevalence of breast cancer. The positive predictive value is now 14%. And the negative predictive value is 99.8%. So it's being greatly affected. And the prevalence at this time in the condition is 2%. And just going up a little bit, but it does affect how that positive predictive value is going to be there. So you would be a little more enthusiastic of using the test based in this higher, older population, or this population with a higher risk than the other. So looking at again, the 2x2 table, just as kind of a refresher, just to kind of do it. So we have the people without the disease, we have the people with the disease. Without the disease, specificity, our test truly rejected, we're true negatives, this is what we have. Our false positives for the people without the disease, this is our type 1 error, just as a reminder. In our disease category, these are people with the disease. We're looking at sensitivity now, and this is the piece. So sensitivity, our test accurately identified the person there for our true positives, but we also have the false negatives, or our type 2 error. And so the question you ask yourself, with this condition, am I focused in on type 1 errors or type 2 errors? So let's take one more condition, and that we can kind of look and see where the test is, in this case, not appropriate. So here's a little case work with me. A resident, Jeff, and his wife have delivered their first baby son, baby Jeff. As part of an investigative study, baby Jeff was screened for muscular dystrophy using a very simple blood test, very inexpensive blood test to evaluate the CPK levels and creatinine phosphokinase level, CPK, in this test. The sensitivity of this test to diagnose muscular dystrophy is 100%, pretty good. The specificity of the test was 99.98%. So you would typically think we're doing a research project, everything else there. So we're kind of thinking hey, this is pretty good. This is a really good test. Muscular dystrophy is a terrible condition. We certainly want a diagnosis. But this is why it's so important to understand sensitivity, specificity, and positive predictive value. And is this an appropriate test to do? Baby Jeff's CPK test was positive. And his father and mother, of course, immediately wanted to know, does our son have muscular dystrophy? Study investigators, again, can we enroll this person in the study? So two questions, right? Does our child, does our baby have muscular dystrophy? Tested positive. The study investigators doing a study of people with muscular dystrophy, can we enroll baby Jeff in our study and see about some of the new research questions that we're asking? To answer these questions, though, we have to know what is the prevalence of muscular dystrophy in newborn males, which is about 1 in 5,000, or a prevalence of 0.02%. So let's walk through it. So it's a technical versus a clinical precision. So baby Jeff, the case of screening for muscular dystrophy at a major medical center. The technical precision of the test, the technical side of it, the sensitivity and specificity, the ability to rule out the disease, the sensitivity is 100%. Great. Specificity, the ability to identify the disease, rule in the disease, is 99.98%. It's good, technically really good. But we have other considerations. To make the calculations, we consider that we are testing, just for the calculation purpose, 100,000 newborn males. Okay. Well, the prevalence is 1 in 5,000. So 20 of these will have muscular dystrophy. We're doing 100,000 people, 20 will truly have muscular dystrophy. The test is 100% sensitive, right? So it's going to accurately identify all 20 of those that have the disease. It will do great. Okay, so we've got all of them identified, no problem. Question though, does baby Jeff have muscular dystrophy? Well, of the 100,000 males, 20 will truly have muscular dystrophy. 1 in 5,000 with a 0.02% prevalence. The test will accurately identify all 20 who have muscular dystrophy. The sensitivity is 100. I know this is repeating, but really is such an important concept. So does baby Jeff have muscular dystrophy? Of the 99,980 babies, of the 100,000 without muscular dystrophy, the specificity is 99.98%. So if we do the calculations, 99.960 will truly have true negative test. We'll test positive, but we will have 20 false positives. 20 false positives. Our conclusions here is that out of 100,000 infants, 20 will be truly positive and 20 will be falsely positive. So our positive predictive value is 50%. This is like looking at baby Jeff's parents and pulling out a coin and flipping the coin to make the diagnosis. Surely you would never do that. We wouldn't do that with any type of condition. It's really there. But this is how it's so important to understand the concepts of sensitivity, specificity, and positive predictive value. We therefore, that a baby with a positive screening test only has a 50-50 chance of actually having muscular dystrophy. Clearly, there's harm here from the clinical standpoint. This is why you don't do CPK tests on all babies, because, and there are many other tests that this is the condition. So getting that concept and understanding this piece is so very, very important. For the research standpoint, clinical standpoint, there's also harm, because half of the people that you've enrolled in your study don't really have muscular dystrophy. So think how bad it's ruined the research aspect of it all. So grabbing this concept is such an important piece. And I just show this. This is looking at HIV, and it's giving you some examples and some pieces that we want to see with looking at the probability of a diagnosis. And this is just a variety of things. I thought it was an interesting piece to kind of look at the diagnostics and the in value and things people have used. You know, are you in the waiting room for HIV or chronic diarrhea, different symptoms that would be kind of coming up, looking at these other tests. But notice you want that accurate diagnosis. And this is what you see with a variety of different types of conditions and a variety of different aspects. So we think about another consideration for sensitivity and specificity. Thinking about sensitivity and looking at that diagnostic threshold. Go through this, and I know this is a lot of material, but another type of piece of this is looking at the diagnostic threshold. This is the typical pattern that we see with almost any test. And this is what you have. You have patients without the disease, and you have patients with the disease. And these are the two, and you have the test results. So you're looking at the accuracy of a test, but you also have to sometimes look at what is the threshold and what's the definition that you're having. So let's use the test, and let's call everything to the left of this line that not people not having the disease as far as the test is concerned, and the people to the right, the people with positives. And so they're going to be testing positives. And so this is a threshold that we want to have. Now, where you're thinking about the threshold is now going back to thinking about the sensitivity and the specificity and thinking about the false positives and the false negatives. Are you more concerned about the false positives? Are you more concerned about the false negatives? And this is how the selection of that threshold would make a difference. So with the threshold here, whatever this is, I've got these number of true positives, which is great, right? But I also have this number of false positives. And so if I want to completely eliminate those false positives, if they're a concern, are they a concern? Then I'm thinking of my condition and what that direction is. Here are my true negatives, but with this test and this threshold, it's going to give me these false negatives. So what is my condition? What am I thinking about? What is the condition that you're interested in? Where are we going with this piece? So I can move, if I move the threshold to the right, let's say I want to eliminate the false positives, false negatives. I'm willing to consider different levels of false positives, false negatives. I move the threshold to the right, and you see pretty much what I'm doing. I'm also now telling people that they don't have the disease, perhaps when they will. You can see the different areas. And what do I want to do? What do I want to eliminate? Likewise, if I can, I'm more concerned. I don't want anybody with the disease to test negative. I don't want any false negatives. I can move my threshold now to the left, and I can start. I'm going to be identifying an awful lot of false positives that you see here, but I'm really not having any false negatives. Thinking of where I want to take that mammography, where do I want to go? And we're just kind of introducing the threshold aspect of it here. So here's one example that we do. And here again, this is going into diabetes and looking at fasting glucose levels to look in there to diagnose pre-diabetes. And again, I'm looking at a sensitivity of 43.8% when the cutoff is the threshold is 5.6 millimoles per liter, with a specificity of 94%. When I take it to the sensitivity to look at diabetes as opposed to pre-diabetes, the sensitivity goes up fairly nicely to 80%, and the specificity goes to 92%. So it drops down a little bit. So now I'm thinking false. Would I want to have a lower number of false negatives and what the conditions are? or do I want a lower number of false positives? And this is how we think and how we move that move the threshold for a particular condition. Going to go into one that's really exciting now in this aspects of it, and I feel we're so fortunate to have two of the global experts in hypertension control, truly leaders, Dr. Welton and Dr. Weber, and kind of want their thoughts in here too, that sensitivity and specificity are associated with blood pressure measurements. And I want to present a few cases that we can look at and kind of consider and ask their input at this particular case. So our first one is looking at the meta-analysis with regards to looking at sensitivity and specificity. And in this particular condition, in this particular scenario, if we look at office-based blood pressure measurements, this is a meta-analysis of 15 different studies, and that's not really that total part. But what this has done and showed is a pooled sensitivity of the office-based, of the initial office-based blood pressure measurement with regards to the identification of hypertension at the sensitivity at 54% and the specificity at 90%. And I might just ask Dr. Weber, Dr. Welton, what their thoughts are at this with this initial office-based measurement in the diagnosis of hypertension.
Well, then I would sort of have to start by coming back with a question, which I know you want me to ask, which is, what is the basis for determining whether someone truly has hypertension? What is the criterion against which the office blood pressure is being compared so that we know whether we're on the right track or not? And of course, it's I know where this is going, because you're going to say ambulatory blood pressure monitoring, where we, for those of you not familiar with it, we do have a device that we can put onto a patient's arm. And for the next 24 hours, it's going to measure their blood pressure. They don't have to do anything about it. It's totally automatic. It's going to measure blood pressure every, let's say, 20 minutes for over 24 hours, give us a large number of readings. And of course, the beauty of doing that is that when you have that many readings and you have an average for the day, you've got a value that is relatively reproducible. So that we can now use that as the real criterion for who's got high blood pressure. So we can compare what we've learned from our office readings, which are far more casual. It's usually just one or two quick measurements in the office. We can learn whether our office readings are really very helpful. And according to this, there is a lot of misdiagnosis based if we just use office blood pressure measurements. Now, Professor Welton, and let me pass the baton to you for a moment. You understood this very well, and you were the leader of a very major clinical trial that's in many ways influenced the practice of hypertension medicine and even the guidelines, the SPRINT trial, where you knew from the beginning that office blood pressure readings can be inaccurate, and came up with a very, very novel and important method that's now become pretty much standard in clinical trials. Perhaps you could explain what you did in SPRINT to make things better, and how something that has perhaps limited sensitivity and perhaps better specificity can be improved further by taking certain obvious steps.
Well, first, let me just make the observation compared to some of the tests that you've shown us, Dan, this one we haven't talked about prevalence yet, but we start with a sensitivity that looks much lower than many of the tests you've been discussing to this point. Specificity, 90%. It's, not bad. You'd like to see it higher, of course. And I think, Dr. Weber, probably what you're talking about is improving the quality of the observation by trying to reduce error. And when we do observations, we see two types of error, random and systematic error. Systematic error are things that you can systematically or with confidence predict will affect the observation. So in the case of blood pressure, systematically, we know if somebody is stressed, their pressures are likely to be higher. If you go to any emergency room, you find a lot of high blood pressures. And there are a lot of other factors that we know to be very predictable systematically, and we try to reduce those by standardizing the way the test is done, in this case, measuring blood pressure. And random error is unpredictable variation. And we find a lot of that in blood pressure. We find it within a particular visit and particularly across visits. So we deal with that by averaging. So that was one of the things we did do in Sprint. We try to control some of those errors to try to improve the observation.
Yeah. For both of you, not to put you on the spot, but y'all are the experts. If a study or if a report said, I'm going to base the diagnosis of hypertension on an initial blood pressure, the first blood pressure measurement in the office-based part. So using all the great procedures, using the great devices and stuff, it would, what would you think about that conclusion? Or would you say I'm not really good with that diagnosis of hypertension?
Well, Michael Weber can address this too, but particularly if somebody just walks in off the street, if they're not familiar with blood pressure measurement, it's a scary kind of a situation. You're usually walking into an office of some sort. Somebody comes in, whether it's a doctor or a nurse or a tech, they're in a uniform. You're nervous already. You're stressed. You come off the streets. Maybe somebody has made you angry. The first pressure may not really give you what you're looking for. When we measure these blood pressures, what we're really asking is for a representation of average blood pressure in that individual. And so oftentimes the first measure will not be very good. If somebody is very familiar with blood pressure measurements, if they're in a study and they have had repeated blood pressure measurements and they're familiar with the staff, it may be better. But particularly in a clinical setting where people usually just walk in off the street and they only come to the office, on intermittent basis, the first blood pressure measurement is often not very good, and in clinical practice we often dismiss that observation.
And Dr. Welton and Dr. Weber, I think that's what we're seeing in this part. The sensitivity is 54%. And I think it's just kind of confirming what you're saying, is that initial office-based blood pressure measurement is exactly what you're saying. And I think the numbers are actually kind of confirming it. These are relatively low values for only the initial base blood pressure. It might, this is kind of the reaction out of that, again, showing you the sensitivity, 54%, 90%. There was also, part of this though, was also looking at the home-based confirmation. Looking at the pooled sensitivity was actually much better, kind of bringing in a lot of the messages that y'all are saying very much needs to be multiple blood pressure measurements, different pieces, conformational. In this particular case, all the conditions that Dr. Welton was referring to that are involved in the office-based blood pressure measurement, the home-based conformation seemed to show a better conformation, an approach that would have it. And these data, looking at the sensitivity and specificity, again, are there, showing this part right up in here, I think is actually confirming exactly what both Dr. Weber and Dr. Welton have said. Screenings using office-based blood pressure measurements had a major high accuracy limitations, misdiagnosis, but also, and however, direct harms, again, of measurements were minimal. So you weren't getting it out here, but there didn't seem to be a number of harms. And this is the diagnosis and the pieces that we have using sensitivity, specificity, and what is the purpose of what you want to do. But the direct harms seem to be minimal.
One of the features of hypertension, Dan, and it's not just hypertension, but other conditions that are based on evaluation of what you might call continuous variables. Blood pressure or hypertension is one. Diabetes is another. At some point, if you're fasting glucose or your hemoglobin A1C is at a certain point, we say you've now got diabetes. If it's a little lower, you don't yet have diabetes. If it's a little higher, yes, you do have diabetes. But in some ways, it's an arbitrary number. The same goes for lipid disorders. So many of our patients these days get treated for their cholesterol levels, their LDL levels, and the use of statins is very broadly based. And again, somewhat arbitrary. What's very different about these sorts of conditions, hypertension, lipid disorders, diabetes, is that we're willing to make errors if necessary. If someone accused me as a physician of treating somebody for diabetes and perhaps they really didn't quite have diabetes, maybe on further testing, they didn't quite reach the criterion, I would shrug my shoulders and say, well, if that happens only occasionally, I'm okay with that, because the natural history of diabetes is that it's going to get worse anyway with aging. So I don't think I've done too much harm. And I think we have to take that into account. This is so different than the wonderful example you showed, the very critical example you showed of breast cancer. You do not want to make a mistake. You emphasize that so well. You do not want to tell someone you don't have breast cancer when they really do, and you have an opportunity now to do something about it that may save their life. With hypertension, with lipid disorders, with diabetes, we're willing to accept some errors in diagnosis. And I think that's a very big difference. I think what we have learned, and again, Professor Welton has been, in a sense, the leader of this, we can afford to be aggressive with treating hypertension. And yes, we may be over-treating people to some extent, but that is a better thing to do than to undertreat hypertension, because overtreating hypertension's got relatively few downsides, relatively few risks, whereas undertreating hypertension can be catastrophic if someone goes on and has a stroke that could have been prevented had we been more aggressive in our approach. So it's philosophically, these sorts of conditions are a little bit different than breast cancer or things along those lines.
I agree completely. And the other thing, we start with the knowledge that these are very common disorders. The prevalence is going to be very, very high. We can talk about a particular prevalence, but whether it's lipids or it's blood pressure or it's glucose abnormalities, if we're in clinical practice and seeing older people, that's going to be very, very common. So it's really going to impact the predictive value of the test.
Perfect. One more, just to kind of share as we look at the numbers, and I think also the kind of attitude, I tried to color code this so that we could move it forward, but looking at from another study, this is looking at the sensitivities for a clinic, home, and a kiosk comparison to ambulatory blood pressure monitoring. Again, we're seeing different pieces in the clinic. Again, a relatively low sensitivity, I think, for the reasons that both Dr. Weber and Dr. Welton have indicated in the clinic. Whereas if we move to the home blood pressure measurement, it's getting around the 82% level. And if we look at the kiosk, we're looking at basically a 96% piece. To everyone's points, if we look at the specificities, again, looking at the clinic, 79%, home 53%, and looking at the kiosk, 28%. Again, what are we trying to do? Where we're going with the diagnosis? Where do we want to? Are we willing to accept a few false positives in order to implement this important position, and looking at what these different conditions are bringing us? Okay, and this other one, looking at different levels, and I think for the sake of time, we'll move this kind of quickly, but showing you at this point now, we have moved a threshold, like we've been talking about, looking at different other types of conditions. Are we looking at this is looking at 24-hour blood pressure monitoring, looking at different thresholds and seeing the sensitivity based on where we move a particular threshold. And that's the take-home piece that we have right here. Just again, the point to be made there. And if we think about the sensitivities again in blood pressure measurement, on the based on a high single visit, high specificity, but moderate sensitivity for identifying awake blood pressure and ambulatory blood pressure monitoring. And again, looking at the sensitivities, again, corresponding sensitivities. What do we want to avoid? The false negative? I think we probably do. And this is we're willing to accept some false negatives that we would have. Thinking about this group, and this is where I would particularly like to hear Dr. Weber, Dr. Welton's thoughts with this. And this is a common condition, more certainly in epidemiology throughout. A simple question: has a health professional ever told you that you have high blood pressure, hypertension, or high blood pressure? Common question we ask all the time in almost all kinds of studies and all kinds of situations, whether it be telephone surveys, regular types of surveys, or any just a pre-screening type of a piece. So I would kind of like to add, and I apologize, I've got my conditions out there, but that the first column should be, those are the sensitivities, and then the parts. But if I could ask Dr. Welton, Dr. Weber, your thoughts on this question and the sensitivity and specificity. Clearly, you've left out the undiagnosed and those individuals that have not had a blood pressure measurement or a diagnosis. But what are some of the thoughts with this question that I know that you're very familiar with, and based on the sensitivity and specificity of this question?
Well, you know, the sensitivities and specificities you're showing here are very similar in a way to what you showed in the earlier slide. And this is a very simple question. I mean, anybody could ask this question. You could have your tech ask this question. It's such a simple question.
Yes.
It will help you a little bit. Sensitivity obviously is not very good, but nonetheless, it will give you some sense that if it's positive, that they're in a higher category. This has some value. It's not perfect by any stretch of the imagination.
So would you say, Dr. Welton, if I'm reading a report in which this was the diagnosis. I should be reading that with some skepticism, I guess
Yes,
you're saying, is it because I'm missing a number of
you
people?
are missing a lot of people here. Yes,
Yes.
yes, missing a lot of people. But nonetheless, if you were in clinical practice before you did the blood pressure measurements, you might ask this question. It would be a very reasonable question to ask, and it might sort of alert you that if somebody said, yes, I've been told 3 times, it would also depend on how often they've been told. If they tell you, you know, I've been to see the doctor, 3 different doctors, and they all told me I had hypertension, I think that would push your sensitivity up quite a bit.
Uh,
So,
and that could be kind of the reaction. Again, it goes back to what are you looking at the test? What do you want to get out of it? And what's the interpretation? And I share from this same study. This is looking at, this is a study from India. And it asks the question, but notice it does, the pattern follows very nicely for the purpose that what Dr. Welton was saying. So here's somebody that has been followed up. They have been doing, and notice that the pattern of have you ever been told, while it is lower, so you have a lower amount of people with elevated from self-report. Yes, somebody told me, but the pattern is quite similar. So it's saying that the differences in here are these undiagnosed, but it looks like the percent of undiagnosed hypertension has kind of been consistent from that type of measurement. So again, what is my question? My question is to intercede that then this is, I'm going to be very concerned about a self-report. If my question is, what are the patterns of hypertension, this might be kind of useful. And to say, I know I'm underestimating what's here, but this is but hypertension is a significant concern.
Yeah, where it's done often, Professor Lackland, in research is, for instance, if I were doing a study on stroke and I wanted to know if the patient, I'm a stroke specialist, let's say, and I am admitting patients to the hospital with stroke, and I want to do a study to see what might have caused strokes and what might have been leading up to this stroke taking place. In some cases, the patients will have documented hypertension that I can see in the records of this patient. But sometimes there is no such thing. And so I'm now going to ask the patient, has exactly the question you just brought up. Has any doctor ever told you, or any health professional ever told you that you've got high blood pressure or hypertension? And the patient or the patient's wife or husband, whoever it is that's with the patient, will say, oh, yeah, I think we were told once that he or she had high blood pressure. So that goes into my research record now as yes, there was a history of hypertension. Well, as you could imagine, that's a little bit weak, isn't it? If that's all I've got to go on, but it may be better than nothing. And that's where you get into this dilemma.
Leading it forward. Excellent, excellent words. Again, just to kind of put it all right here together, sensitivity, specificity, positive predictive value, negative predictive value that we end. Again, sensitivity deals with people that have the disease and concerns about the false negatives. Specificity deals with the people that do not have the disease, and the concern are the false positives. The positive predictive value, again, deals with people that tested positive. Again, at that point, the false positives are an issue. And the negative predictive value deals with people that do not, that tested negative, and our concern is the false negatives that we bring. So real excited about having this hypertension discussion, and hope you are too. Each of you should be receiving the World Hypertension League newsletter and building. There can be more of this aspects. Again, our reminder at the of our the series right up in here. We're posting the questions, your answers to your questions, and those are posted on the World Hypertension website. We will continue to do that and hope you would visit that. With the also, we want to emphasize our sixth World Hypertension Congress that will be coming up in Chennai, India in February. I think a great opportunity. We'd love to have you participate with us. I think it would be a great thing. There'll be more of this type of discussion. You'd even have the opportunity to meet Professor Weber and Welton in person. And I know that would be a good piece. And again, just a great opportunity.
And Dan, you're going to be leading a workshop on scientific writing. And if somebody is working on a paper or thinking about a paper, that's a fantastic one-on-one setting to bring that paper. And there'll be opportunities for publication of abstracts and potentially papers in our journal, the Journal of Human Hypertension.
Perfect. Perfect. And that leads right where we are. Welton has said it. We will have a writer's workshop type of stuff that we'll do on the mornings of each morning of the conference, and that would be here early in the morning. This is what we have and are excited about it, and we would love to have your participation there. We think it'll be good. And to echo what Dr. Welton was saying, this is an opportunity to meet with individuals to work with your paper and to consider what some of the work that you're having with publication. There's also the abstract submission opportunities that are there. It's open, and we'd like you to encourage maybe thinking about going in that direction.
And the people you meet there, it's interesting. They not only submit a lot of papers for publication, so they know that part of it, but they also, like the three of us, have served roles or are serving roles as editors, and in the case of Dr. Weber, editor-in-chief. And so they know what happens at the other side of the table too, as you're going through those papers. Why do you pick one? So it's a very nice in-person opportunity if you're thinking about writing a paper.
Sounds great. And thank you. And with that, Kesser, we'll stop here.
I can't believe an hour and a half has gone by. It seems like 15 minutes.
Okay. now we have a poll question.
We're coming to everyone's favorite part now. So you have heard from the professors. Now we turn to you for consultation and present to you the first scenario, which is that an investigator has developed a specific diagnostic test for gestational diabetes. This test is inexpensive at $1 per test, and the investigator proposes testing all pregnant women in the region to determine the prevalence of gestational diabetes. Sounds like a good idea. The test has a sensitivity of 95% and a specificity of 50%. So the the chat bot is, okay, hiding my text. The regional medical director asked for your advice on implementing the proposal in the next year. So so I am going to let you look at the 4 choices we present here and type your preferred answer in the chat box, please. Coming in. Seeing lots of A's. Okay.
Guess we can maybe start kind of discussing it. This is everybody's kind of in the right, you're in the right area. I would have gone with C, and thinking about it, because again, the purpose was to determine prevalence, and what you're having is a relatively low specificity, and so the test might be missing a number of people that and so it would be you might be missing it for the prevalence. But if you kind of had that other attitude, getting the test out and building it forward, it's an inexpensive test, and we see this all the time. So I guess this is kind of one of those where there's not one or two absolute right answers. Well, actually, the A and C would be a couple of the approaches. But again, you want to kind of focus in on what is there. And if you wanted that true estimate of prevalence, I would be a little bit concerned with this test, just my opinion.
Mm-hmm.
Yeah,
Absolutely.
you bring up a really good point that, you have to consider everything. Cost is one thing, feasibility is another thing. But looking at both specificity and sensitivity is important in making those decisions. And Sushma, do we have time for one more scenario?
Sure.
Okay.
Quickly.
So here's the second scenario. An established primary care clinician has purchased a multi-test battery for her patients. The test includes an assessment of a new, very small lipid subfraction, where there are virtually no studies or evidence of any effects. Further, the sensitivity and specificity are both, are respectively 15% and 20%. So during a discussion, she asked you if she should continue this measurement in her clinic. And your choices are, if you could go to the next slide, please. Okay, so we'll give you a minute or so to choose your preferred answer and type it in the chat box. What advice would you give her?
These are great answers, and everybody's kind of responding. First off, they're all right in one sense, but as we would look at that the test is a little bit made up by me, but I think these are all reasons that you would probably not want to do this measurement. And again, going back to, why do you do a diagnostic test? Because you want to do something. And in this case, I don't think that there's anything that you could do with this particular diagnostic test as a routine. But I've certainly asked Dr. Weber, Dr. Welton, what their thoughts are for these kinds of tests. And you do see them quite often sometimes.
Yeah, you hit the nail on the head here. I would certainly say all of these things apply, so I'd pick D.
Absolutely. And there are so many of these things going on in modern medicine, and whole stores offering tests and remedies that some of us have not even heard of before, based on this sort of very questionable approach. No, I think D was the right answer here, and it's a very good example.
Well, thanks everyone for your participation, and now I'll turn it over to Sushma to wrap it up.
Thank you, Kessler. Thank you, professors, for this very, very informative session. Looks like there was a little bit of confusion in one of the slides we presented, so I'm just going to share the slide and would appreciate your insight on it, Professor Lackland. I guess many of us are very, very used to seeing the standard test or the gold standard in the columns and the index test in the rows. And here you had it flipped.
Right,
And
correct.
then there was a question about people were not very, I guess, used to seeing this 2x2 table. So I guess we would like to know whether we could do it, or is it important that the gold standard test be always on the column and not in the rows?
So it's a brilliant question, and I will do. This is just kind of one of my strategies, and I appreciate everybody that saw that and asked that question. Thank you very much, and that mission accomplished. It's so important, I think, to make sure that we know what the columns are and what the rows are. And I purposely did it like this, and I've done this in my classes like this to make sure that you keep thinking, that you're looking at this part. But your point is extremely well taken, and and so I congratulate you for keeping up with it. But this was a deliberate act just to keep people keep people thinking about it. But you want to read those labels and make sure that you're in the right spot.
Great, thank you so much for. So I'm gonna just switch now and just tell everyone that we have scheduled our next session on September 12th. And please note that it is not on third Thursday that we usually do, but we happen to do it next time on the second Thursday, but at the same time. And the session will focus on predictive value and diagnostics. So please mark your calendar, register, and plan to attend. And this is all we have for today. And we thank professors and WHO faculty for this wonderful, wonderful presentation. We appreciate all of your time and attention. And please use the QR code on the screen or the link that we just put in the chat box to complete the evaluation for the session. Your feedback is very, very important to us. And we look forward to seeing you all next month. Have a wonderful rest of your day, and goodbye. Thank you very much.